And leadership reflection video for 4010 Leading People, Processes, and Organizations in Interprofessional Practice. My name is John Humphrey. In this video, I will reflect on personal experiences of interdisciplinary collaboration, discussing the factors that contributed to its success, as well as challenges that hindered the achievement of desired outcomes. I'll explore how ineffective collaboration can lead to mismanagement of human and financial resources, highlight leadership strategies as identified in the literature that can enhance an interdisciplinary team's ability to accomplish its objectives, present evidence-based strategies in improving interdisciplinary collaboration to foster teamwork and achieve collective goals more effectively, and reference key authors and findings from the literature to support my discussion. In this scenario, I will describe occurred on the mid-surge unit while I was working as a registered nurse. It involved an elderly woman who I will refer to as Jenny, who was admitted to the hospital because she was feeling just generally unwell. Jenny was being cared for at home by her husband, who I'll, for the sake of this video, call Jerry. Jenny had devoted much of her life to volunteering in hospice care, demonstrating a deep commitment to helping others. She was a spirited individual who cherished her life. Jenny had been hospitalized numerous times in the past, and the staff were familiar with her and the gradual decline in her quality of life over the years. This decline was primarily attributed to the progression of her medical conditions, including MS, muscular dystrophy, and Parkinson's disease. Over time, she had lost her ability to walk, which further impacted her independence. On this occasion, her husband, Jerry, who was also elderly at the time, contacted emergency medical services when they noticed that Jenny had appeared a little bit more ill than she normally was. Emergency medical services transported Jenny to the hospital, where she was assessed in the emergency department and diagnosed with sepsis. She was admitted to the ICU at the time and placed in a medically induced coma for a week. Her husband was deeply distraught. They'd been married for over 40 years, and he was kind of struggling to cope with the situation that she wasn't in the best health at the current moment. Their relationship seemed to embody the ideal partnership, making the situation even more heartbreaking. After her condition improved, Jenny was transferred to the med-surg floor, where she was extubated, somewhat medically stable enough to leave ICU. Upon the arrival to the floor, Jenny was hemodynamically stable, but she was frequently disoriented. As a result, her husband assumed responsibility for her medical decisions. When the staff attempted to encourage her to eat, they discovered she was unable to swallow safely. The speech-language pathologist was consulted to perform what's called a swallow evaluation, which confirmed the issue. Intravenous fluids were initiated to maintain her hydration over time. Her condition worsened. She remained unable to eat and became increasingly lethargic. The few words she could manage during care tasks, such as repositioning and changing, were expressions of distress, repeatedly saying, "Please stop," or "No more," "Please no more." Recognizing Jeannie's previous way of life, I quickly came to the realization that she was unlikely to recover and return home. Understanding the importance of addressing her future care, I initiated conversations with her husband about advance directives, as she was still classified as full code. During the discussions, he expressed, "I know she wouldn't want to live like this, but I'm not ready." Respecting his feelings, I refrained from persuading him to make any immediate decisions. Instead, I provided him with informational material about advance directives and about social work in her case for additional support. Over the following weeks, Jenny's conditions deteriorated further. She became profoundly lethargic and was unable to eat or drink. The certified nursing assistants ensured that she was repositioned every 2 hours and completed regular mouth care. Despite the clear decline in her prognosis, the medical team continued aggressive treatments to prolong her life. Jenny was administered IV fluids for hydration and vitamin supplements to address her malnutrition. Though these were temporary solutions, the care team attempted to discuss hospice care with Jenny's husband, but he firmly declined. In response to the treatments continued, and she was placed on parenteral nutrition. While these interventions extended her life, they did not improve her quality of life. Jenny frequently pleaded during care, saying, "No more, please, no more." Despite her clear expressions of distress, her husband maintained decision-making authority and insisted on continuing treatments, as Jenny was not considered competent to make her own medical decisions. Eventually, after all that had been exhausted, the decision was made to perform a lumbar puncture to test for Guillain-Barré syndrome, a condition in Jenny's medical history. Although it was unlikely to yield a positive result, her husband insisted on the procedure and signed the informed consent form. Despite the anticipated pain associated with the test, he was adamant that it be carried out. As preparations for the procedure began, her husband sat just outside the curtain when Jenny cried out, "Stop, no more, please." He broke down emotionally, admitting maybe he was in the wrong. Maybe this isn't what she would want. "I think I should have said no." I, being the nurse, reassured him, speaking through the curtain, that he could revoke his consent at any time, and the procedure would be stopped immediately. He responded, asking for us to halt at the test. However, just as that decision was made, the physician successfully located the appropriate site and retrieved the fluid. Hearing this, he hesitated. He said, "Well, might as well get it done." The test was completed and planned, and as expected, the results came back negative. Following this, the provider revisited the topic of end of life with Jenny's husband. This time, he acknowledged that she would likely not want to continue living under such circumstances. We discussed advance directives and hospice care, but he still struggled with the thought of losing his partner. To support him, social work and counselors were brought in to help navigate her wishes and the reality of her prognosis. Recognizing her pain, he agreed to initiate round-the-clock pain medication. After a few days, he made a difficult decision to change her code status. In the interim, we continued to provide total prenatal care, or parenteral care, and pain relief. Ultimately, he agreed to transition her to hospice care, and the process was set in motion. Unfortunately, Jenny passed away before hospice services could officially begin. However, the hospice team remained available to support her husband through the entire bereavement process. The scenario involved extensive interdisciplinary collaborations, including emergency medical services, the emergency department, speech therapy, nursing, social work, the ICU, hospitalists, nutrition services, and hospice. Throughout her treatment, each team worked to prolong the patient's life. Nursing staff, social workers, and hospitalists made repeated efforts to educate the patient's husband, who served as her healthcare proxy, about alternative care pathways. However, it wasn't until he was emotionally ready that he agreed to transition her care. Reflecting on this case, I wish I would have been able to reach an agreement for comfort-focused or hospice care sooner. I think this could have spared the patient from undergoing numerous painful tests and procedures. Moreover, it might have allowed her to pass away at home, which she was frequently expressed as her preference during the hospitalization. The absence of advance directives contributed to unnecessary tests and placed significant emotional burden on her husband as the sole decision maker. One way the situation could have been improved is through early planning to ensure that the healthcare proxy understood the patient's values and made decisions aligned with her wishes. According to Fong 2020 in the article Understanding Advance Directives, an unprepared healthcare proxy is more likely to make decisions that lead to unnecessary and burdensome interventions, often inconsistent with what the patient would have chosen for their care if they were able to decide. Although the patient was eventually transitioned to hospice care, she did not live long enough to benefit from the full range of the services hospice provides. If advance directives had been documented earlier, the husband might have found solace in knowing he was respecting her wishes. This could have reduced the use of unnecessary medical interventions and allowed her to experience greater quality of life during her final month. Regular and open discussions about the patient's values, goals, and preferences for future care are essential in ensuring their quality of life. Advance directives play a crucial role in preserving a patient's autonomy when they can no longer speak for themselves, according to Goswami in 2020. Despite the patient's longstanding diagnosis for muscular dystrophy and Parkinson's disease, palliative care was not discussed with her or her husband. This oversight represented a missed opportunity to provide her with autonomy and control over her care as well. Palliative care offers several key benefits, including improved quality of life, effective symptom management, and support for the family decision making. By prioritizing patient-centered care that considers the desires and needs of both the patient and their family, we can better align treatment values and provide more passionate and appropriate care for patients and families.